This is Dr. Wiquar, consultant pain and spine, consultant pain specialist, Alleviate and Alleviate Hospital, Bangalore. So first of all, welcome you all to this interactive session. And shoulder pain is one of the commonly presented with your back pain and knee pain to any of our pain clinics. And the reason is that it's just a basic introduction if I have to give. It's an union between two bones. This is the humerus. This is the scapula, which we call. And it's a very mobile joint. Although the stability gets compromised because it's very sort of an open joint. It's a synovial joint. And but it is stabilized by multiple rotator cuff tendons which come and attach it. And, they don't allow it to get dislocated. That could be the area from where the pain can also be generated. And, Ilmaz, any questions?
Yes, doctor. We got some questions in the chat box. So, the first question is that they've asked about the causes. What would be the causes of the shoulder pain?
Yeah, for that, the basic thing, as I explained to you, it's a joint. There are two bones here. There's a joint which is formed here. So whenever there is a joint, there will be cartilage which will be there. There will be wear and tear of that. So there could be arthritis, which is, which could be there. There are other joints also involved. There are small joints. This is, your clavicle, your collarbone, which is coming and attaching on the top. And that forms a very small joint, an AC joint.
Mm-hmm.
Same collarbone, it can go, towards your chest, and your sternoclavicular joint is formed. So these are the three major joints which could, cause. There is another is your not a true joint, but the scapula again, where it goes and sits on your ribs. So
okay,
these can be the areas from where the pain from the joints can arise. The other things are, these things, these are called as rotator cuff tendons, where the muscles come and they attach. So basic concept which I want to introduce is that two bones being connected, they are connected by a ligament. And when the muscle as such becomes tough and that comes and attaches to the bone, that is called as a tendon. So these are all tendons where your muscles come and attach to your, the bone. These areas where they are coming and attaching, those areas, there can be tendinitis, there can be tendinopathy, there can be tears. All these things can be there. There is a capsule there which surrounds your joint, and that also there can be adhesions in that. It can become sticky, and that is called as frozen shoulders.
Yes.
And there are other, when there are two muscles or group, there you have some spaces in the middle, as these act like cushioning areas, and these are called bursae. And these bursae can also get inflamed, where fluid can get accumulated in them, and those can also be connected with your joint also. So these can all be the causes of shoulder pain.
Yeah, and the second question was about the frozen shoulder. The doctor already has explained. Okay, so when it comes to the treatment, doctor, what can be the treatment for the frozen shoulder?
So frozen shoulder, first you have to diagnose it. So, there will be joint restriction. Initially, how it starts is that it's commonly seen with diabetic patients. It can be post-fall, post-trauma also, where the patient stops using their hand. And the painful stage will be there, then it gets frozen. And if you just leave it like that, it will take about 2 years or so for the range of movements to come back. So usually the patients come to us, they say that night they have more pain. And the movement is completely, this external rotation is completely blocked, where the patient is unable to move properly. The range of movements, putting your hand behind, the basic needs like combing of hair, wearing their dress or blouse, and putting your hand in your pocket itself becomes very difficult. Many of our patients who come, they complain that even for past 6 to 8 months, we are not able to put, our wallet into place or comb our hair properly. These are all, the quality of life of the patient is, quite bad. So these will be the common complaints where the patients come to us with. And once we diagnose it, there are two things. One is a physical examination, which is very, very important, because shoulder joint also, you can have a lot of confusions. If it is actually coming out through, your problem, your pain generators, are they in your tendons, or they are in your joint, or they are adhesive capsulitis. One very important thing which we need to understand is the joint is normal in adhesive capsulitis. It's the capsule which I told you it surrounds, and there are adhesion. The stickiness is formed, not the bones or the cartilage in as such. So it's very important for us to differentiate it with there are a lot of physical examination. You have to touch the patient, you see all the special tests, you rule out, and then you jot it down, and not mandatory that you have to send for a lot of investigations initially. We at Alleviate, a very important aspect for especially your shoulders in our examination is ultrasound examination, because the ultrasound it helps, and these are areas which are quite superficial, and hardly about half a centimeter or 1 centimeter where you can see. So the front area is scanned, the area behind, posterior area, laterally. We also have different manuals, and we investigate it properly, and then we come to a conclusion. So once we have diagnosed it as frozen shoulder as such, there are many treatments which we can do. One of them is a part of regenerative. So regenerative therapy, where we use PRP. There is the supply of the shoulder is by about 3 nerves mainly. So one of them is a scapular nerve, which is behind. So it is in this this fossa. You can see there is a fossa here. So it just passes through this, passes like this. So this nerve can be, because the patient who comes to us, initially they want pain relief. So pain relief can be given by this, and then the physiotherapy takes over. And the shoulder joint itself, where the adhesions are there, we can, dilate that. We don't need to use any anti-inflammatory medicines, or we can use normal saline with local anesthetic to actually distend that joint. Previously, it was so that we didn't have any other option for adhesive capsulitis, wherein the patient had to suffer with pain or do the physiotherapy. Unfortunately, when the pain is more, the patient will not be able to mobilize. However, the physiotherapist tries to, it gets blocked after a while. So the patient is unable to do it. So we give them that extra thing. And then the physiotherapy also plays a very important part, where the patient has to do his. And one more thing, you should remember that these are all chronic patients. Chronic, when I say they are suffering for more than 3 months. And when that happens, the muscles, the tendons around the joint become weak. And so in turn, there will be involvement of your tendons as well also. So you have to take it quite slow and build it over a period of time. So long-term physiotherapy or strengthening exercises is the key.
Okay, doctor, thank you. And the next question is all related to arthritis, doctor. So we all heard about arthritis of knee. So what is arthritis of shoulder? So how it is significant?
See, arthritis of shoulder, of course, it's not as common as your knees, as we are seeing, shoulder arthritis after about age of 65. Or else if you have any inflammatory arthritis, it can be involved, like rheumatoid arthritis. The difference between normal arthritis and your inflammatory problems, wherein the patient will complain of more pain in the morning hours. And if the patient doesn't do any activity, like he sleeps and wakes up, that inactivity actually causes more pain. That is more of pointing us towards young patients having shoulder issues and all, that we have to look into an inflammatory problem that has to be ruled out first. The other thing is, when there is degenerative, meaning workload, usually drivers, heavy load drivers and all, they do develop. So they beyond about 65 years or so, the incidence can be about 7 to 8%. It's not very common, but so arthritis, what basically happens is those two bones which are coming, they are aligned in such a way that, it's like a ball and socket, but it is not a very close joint like your hip. It's more of an open joint, but it is more stabilized because of the rotator cuffs which come and attach and don't allow the humerus or the arm bone to actually dislocate. So arthritis, again, there will be on X-ray, you can find out that the space between the two bones is reduced. That simply means that there's wear and tear of the cartilage which is present at that place.
Okay, doctor. So you have explained about this ultrasound and X-ray plays a role in diagnosing the shoulder disorders. What about MRI, doctor? How is MRI required? Is MRI required for all the shoulder pain or shoulder disorders?
No, MRI is not required for all the shoulder problems. Many a times it can be diagnosed. See, this is what I'm telling. If the patient is complaining, the key in shoulder examination is the dynamic examination. Dynamic examination, when I say that, it is you are able to move the patient's arm or the shoulder and then elicit it, that which is the most painful area, which you will not be able to do when you are doing you have done an MRI. It's basically a patient is lying down and you have taken the pics. Definitely there is a role of MRI in shoulder in cases where there is complete thickness. For example, rotator cuff tears are there, which can also be picked up with your ultrasound. And the benefit of ultrasound is you can do it in your clinic. You can do it multiple times, and it is very cost effective. It is safe. There is no radiation. You can do it on a pregnant lady. And these are all very important things which we should know. And the ultrasound thing gives, you can keep the probe and move the limb. You move your shoulder and see those specific areas which can be picked up. And if you have further any queries, or if you are doubtful at one location, you can definitely send the patient for MRI. But for each and every patient with shoulder pain, it is not required. Yes.
Okay. So the next question, doctor, is about the non-surgical treatments that we do at Alleviate for the shoulder pain. So what are those non-surgical treatments and benefits of those treatments?
Fine. So first thing is, when a patient comes, as I told you, we do an examination, then we do an ultrasound examination. For the different locations, what we basically do is we have a protocol which we follow. The diagnosis is the key. Once we have diagnosed, for example, a rotator cuff where a tendon is coming and attaching, a tendon comes and attaches to the bone. You can see that it's coming and attaching. That area on ultrasound is magnified. You can see the fibers like white and black lines. And if there is a disruption in that, you find which area it is disrupted. And if there is when there is a partial thickness tear. Of course, when completely torn, you cannot do anything non-surgically. See, you have to refer the patient for surgery. But in case where there is a partial thickness tear, and lots and lots of studies are there which point out that your PRP treatment, where we take the patient's blood, about 20 ml to 30 ml, depending on which kit you are using, that can be centrifuged, and the PRP component, about 1 to 2 ml in case of a rotator cuff tear, can be taken. And that, via an ultrasound guidance, you can deposit it in those areas, which the areas when I'm saying are hardly about quarter or half a centimeter, and that can be localized and targeted with PRP. This is one thing where rotator cuff we can do. There's something else which regenerative therapy also is, where we are trying to heal the area. It's not just pain management. So previously we were concentrating only on pain management, wherein we are not bothered about the healing. We couldn't do anything about it. But we used to concentrate only on pain management. But now it so happened that we use regenerative measures. In regenerative therapy, you get your PRPs, your stem cell therapy, your prolotherapy. Now, prolotherapy is again a very simple yet very, very effective and modality, where what we do is we inject irritant, so like dextrose, sweet water, which is very natural. And the benefit of even regenerative, including PRP, prolo, stem, and all that, is that there are no side effects, because it's your own blood which we are taking, or sweet water which is present in our own body, and the local anesthetic is mixed in a proper proportion, and those with via very, very small thin needles is injected around the area. So any problem, let it be your shoulders, let it be your knees, or any other place, your back, the major thing which is happening is instability. When there is instability between two bones, they can run. And that is the time when any problem can start. When the joint becomes stable, it's a long-term pain relief for the patient. And where the healing, you deposit these injections in and around the areas where your ligaments and your tendons come and attach. These are called entheses, and those areas you can actually inject and strengthen the joint. The rest, degenerative, like as I told you, if the patient comes to us with arthritis which is quite progressed, in that case, for the pain relief, actually, we do something that is, cool radio frequency ablation of the nerves which supply to the joint. So these are only pain nerves which are taking pain from your shoulder and going up. So they have no other property. They don't affect your sensation. They don't affect your motor strength. These are very small nerves which can be heated up at a proper location via your ultrasound guidance or your X-ray guidance. And those again reduce the pain. And application of even something like a Botox is also there, where the receptors which are present from where the pain is picked up from the joint and it's taken up are blocked.
Yes, doctor. So all these treatments, what we are doing at Alleviate is outpatient procedure, right? It's not hospitalization is not required for all these, right?
Yeah, actually, we have got one hospital and we have got three pain management centers. Even at our hospital, these are all daycare procedures. These are all conducted under local anesthesia. There's no general, although my background is an anesthesia background. We do believe in multidisciplinary approach to pain. We have orthopedicians, spine people. We all as a team are practicing non-surgical means, and we are all the procedures which we do are daycare procedures under local anesthesia and guided procedures. The key to it is guided procedures, because where I'm speaking about a tendon is hardly this much, it's about a centimeter, and you have to be very precise so that you are more precise and safe also, because you're working here with areas which are very close. For example, not only in your shoulders, even in your knees or even in your chest. If you are actually doing any procedure as such, the safety is also of prime importance.
Yes, doctor. So we are done with the questions now. So yeah. Okay.
Yeah. So not only the shoulder, the application of when a patient comes to us with frozen shoulder, and we have diagnosed the patient to have adhesive capsulitis. So, and the patient would have gone to multiple places and got physiotherapy done and all these things done, and the pain is more. When the pain rate, you rate the pain, the patient says it's maximum, sir. So that moment we give the patient the pain relief, meaning we actually distend the joint or hydrodilate the joint, and the nerve interventions are all done, where the patient gets pain relief, can be followed with intraarticular injection of PRP, which works really wonderfully well. This can be followed about about 3 weeks or so, and then it can be about two sittings can be done, and PRP can also be done. And bursa is also one area which causes pain for the patients. And bursa and we call this tendon sheath injection, where there is your biceps muscle comes and attaches. It goes and attaches to the joint actually. So this area also, if the patient complains of severe pain, the pain can be referred down. The patient will not come and tell us that it's typically only in the shoulder. The shoulder is also an area where you can have reference from other areas, wherein even a gallbladder problem can refer, or a left side cardiac problem also can refer. So it's very important for you to sort out, and diagnosis is the key in any problem as such. And in purely in shoulder, so it is very, very important, where your restriction of movements, or even where you need to also differentiate is if the pain is coming from the nerves. So for example, even a patient with something called as, there are facet joints here in the neck, and those joint problems also can refer down. This is a trapezius muscle which forms the neck, which connects your neck to your shoulder. That muscle also can cause the pain. So these muscles also need to be targeted with, you can target it with prolotherapy, as I told you, with trigger point injections. You can do dry needling. Again, all these things are directed injections, wherein you can see very clearly of where you are going, because the neck area and all these are very critical areas where you've got arteries, you've got nerves, you've got veins, and you don't want to go or touch even these areas. So it's very important for us to do. For example, if it's coming from your muscles, you can do your dry needling, you can do wet needling, or your trigger point injections, you can do your prolotherapies. So it's very important for us to know that where exactly, or even your neck cord compression, or you must have heard about disc compression. So even if there is any disc compression as such, and that can also cause the pain, referred pain. So it's important for us to note from where it is coming. So this is the key. Any other questions are there?
No, doctor, that's it. We are done with the questions now.
Adhesive capsulitis is something which is very, very commonly seen with the diabetic patients. Usually the incidence is hardly 2 to 3% normally, but in diabetic patients having it, about 8 to 10% of diabetic patients get it. And most of the patients, you can tell about 60 to 65% of diabetic patients, or most of the about 60 to 65% of patients with frozen shoulder have diabetes. So that's an important thing. And the most key is also, which we don't understand, is to maintain and to keep our sugar levels in check, which, because if your right side gets affected, you don't do anything. Previously, what they used to do is, as an anesthetist, we used to give anesthesia, and it is, mobilized. Under GA, you are just manipulating it. But after post-op, pain is quite a lot. And also the thing is, when right side is affected, the left side can also get affected after that. So it's very important for us to keep our sugar levels in control. And physical therapy plays a very important role, which we at Alleviate concentrate a lot, where all our centers and our hospital, we have got a dedicated physiotherapy team, which takes care of that, which helps you get over it. Of course, it doesn't happen overnight. It takes its course, where we manage the pain, and for the patient to come back to his thing within a few weeks. These our physiotherapist help them out. Fine.
Okay, doctor.
If there are no questions, we can.
Sure, doctor. We can wind up.
Yeah. Okay. Thank you, Almas.